Welcome to Edumaniac. Today we are going to discuss a truly fascinating, albeit uncommon, gastrointestinal condition. We are doing a complete clinical deep dive into achalasia. We're going to look closely at exactly what happens when the normal, rhythmic movements of the esophagus literally just stop working and why it happens. We've mapped out absolutely every crucial detail for you, so let's jump right in. Here is the roadmap for today's explainer. First, welcome to achalasia. Second, pathology and etiology. Third, the Chicago classification. Fourth, clinical features and diagnosis. And finally, treatment and management. All right, let's start with section 1. Welcome to achalasia. So, what exactly is it? Well, the term achalasia actually comes from Greek, and it translates to failure to relax. And honestly, that perfectly describes the mechanical failure we're dealing with here. It's an uncommon motility disorder that's fundamentally caused by the selective loss of ganglion cells in the myenteric plexus. You might also know this as Auerbach's plexus, which sits right there in the lower esophagus. Because these specific inhibitory neurons are lost, the lower esophageal sphincter starts acting like a really stubborn bouncer. It simply refuses to relax and let food pass into the stomach. Moving right along to section 2, pathology and etiology. Now, you might easily confuse achalasia with another condition called Hirschsprung's disease, but there's a really fascinating distinction between the two. In achalasia, the dilated, swollen portion of the esophagus actually contains very few ganglion cells. But if you contrast this with Hirschsprung's disease in the colon, the massively dilated segment actually contains normal ganglion cells, and it's the constricted segment downstream that's aganglionic. It's a subtle difference, sure, but pathophysiologically, it's absolutely crucial. So why do these ganglion cells just pull a vanishing act in achalasia? Well, the exact cause is generally a mystery. However, if we look geographically, it's worth noting that in South America, a chronic infection with the parasite Trypanosoma cruzi, which causes Chagas disease, presents with marked clinical similarities. Physiologically speaking, the classic signs you're looking for are a non-relaxing lower esophageal sphincter, or LOS, and completely absent peristalsis in the body of the esophagus. Think about it. The esophagus can't squeeze food down, and the sphincter at the bottom won't open. So the esophagus empties mostly by the sheer hydrostatic pressure of whatever is stuck inside it. Over time, this incomplete emptying stretches the tissue out, resulting in a tortuous, dilated mega-esophagus. And this leads to a highly dangerous situation long-term. All that stagnant food ferments, causing persistent retention esophagitis, which significantly spikes the patient's risk of developing esophageal carcinoma down the line. Which brings us to section 3, the Chicago classification. Thanks to high-resolution manometry, version 3.0 of the Chicago classification breaks achala down into 3 distinct types. Notice that across all 3 types, the integrated relaxation pressure, the IRP, is elevated above 15 millimeters of mercury. That's your proof that the sphincter isn't relaxing. Now, type 1 is your classic achala, 100% failed peristalsis with essentially 0 recognizable contractions. Type 2 also features 100% failed peristalsis, but its key feature is pano-esophageal pressurization, occurring in at least 20% of swallows. Basically, the esophagus acts like a single pressurized common cavity. Finally, we have type 3 or spastic achala. Here, there's no normal peristalsis, but you do see premature high-pressure spastic contractions. Why does this matter to us? Because understanding these specific types is a total game changer for predicting exactly how well a patient will respond to different treatments. Let's dive into section 4. Clinical features and diagnosis. How does a patient actually walk into the clinic presenting with this? Well, it's most common in middle life, though it really can strike at any age. The textbook presentation you're looking for is dysphagia, just straightforward difficulty swallowing. But here is the absolutely crucial takeaway. In the early stages, patients frequently present with chest pain. And guess what? This is incredibly often misdiagnosed as simple gastroesophageal reflux disease, or GERD, meaning patients can go untreated for years because of a simple mix-up. As the disease progresses, regurgitation becomes super frequent, and because the esophagus is just sitting there full of undigested food and fluid, there's a huge risk of overspill into the trachea. This is especially dangerous at night when the patient lies down to sleep, leading to aspiration. Now hold on, because there is a massive medical curveball you need to be aware of: Pseudo-Achalasia. Classic achalasia is a primary disorder of the nerves. Pseudo-Achalasia looks identical clinically and radiologically, but it's actually caused by a physical mass, most commonly an adenocarcinoma of the cardia, or sometimes a tumor from the bronchus or pancreas. This is exactly why ruling out tumors is absolute step one before you even think about treating for a primary motility disorder. When looking at a classic barium swallow for this condition, what immediately stands out is a smooth, tapering stricture right at the lower end of the esophagus. It narrows perfectly to this bird's beak point, showing you exactly where the sphincter is stubbornly refusing to open. In a late-stage manifestation, you'll see severe tortuosity, where the esophagus takes on a highly dilated, almost sigmoid appearance, creating that massive fluid-filled mega-esophagus we talked about. And notice what's missing. The normal gastric gas bubble is usually entirely absent. Why? Because air simply cannot pass through that tightened sphincter. While barium swallows are super helpful, high-resolution manometry is really the definitive gold standard diagnostic tool. This color-coded topography maps out the pressure in the esophagus during a swallow. You'll see a bold band of continuous high pressure at the bottom. That's our non-relaxing lower esophageal sphincter. A swallow initiates, but there is zero relaxation, and instead, a positive pressure gradient builds in the esophageal body right above it. This gives us direct, visual confirmation of the physiological failure. And that brings us to our final part, Section 5, Treatment and Management. The great news? This condition uniquely responds incredibly well to treatment. We have 5 core modalities at our disposal. We can forcefully stretch the muscle with pneumatic dilatation, we can surgically cut the muscle via a Heller's myotomy, or we can do it endoscopically with a POEM procedure. For our less fit patients, we can use botulinum toxin for temporary chemical relaxation, or rely on specific drugs like sublingual nifedipine for transient short-term relief. Let's break down the mechanics of the major ones. To perform pneumatic dilatation, a plastic balloon dilator is used to forcefully stretch the cardia. Now, the goal here isn't just a gentle stretch. We actually use forceful dilation to disrupt and tear those non-relaxing muscle fibers. We use really precise balloons, typically 30 to 40 millimeters in diameter, inserted over a guide wire. And don't worry, if the pressure gets too high, these balloons are engineered to split longitudinally rather than expanding further, which protects the patient. With a 30-millimeter balloon, the major complication, perforation of the esophagus, happens in less than 0.5% of cases. It's a highly effective technique with a curative success rate of 75 to 85%, especially for folks over the age of 45. Now, forceful stretching isn't the preferred route, or if it fails, we turn to surgery, the Heller's myotomy. This involves physically cutting the muscle of the lower esophagus and cardia to completely abolish that tight sphincter. But think about the structural consequence of destroying that valve for a second. You'd get massive gastroesophageal reflux. To prevent that, surgeons almost always pair the myotomy with a partial anterior fundoplication. It's often called the Heller door operation, where they wrap a portion of the stomach around the esophagus to recreate a one-way valve. This is ideally suited to a minimally invasive laparoscopic approach, and the long-term success rate is phenomenal, working in over 90% of cases. We also have newer, non-surgical alternatives. POEM, or per-oral endoscopic myotomy, was introduced in Japan back in 2009. Instead of cutting from the outside in, the endoscopist creates a tunnel entirely under the mucosa from the inside, performing a long myotomy without a single external incision. It's pretty amazing. If a patient is elderly or has heavy comorbidities making them unfit for surgery, we can inject botulinum toxin directly into the sphincter. It blocks excitatory neural activity, relaxing the muscle, but keep in mind the effect is temporary and has to be repeated every few months. Finally, while long-term drugs are generally ineffective, sublingual nifedipine, which is a calcium channel antagonist, can offer transient symptom relief if definitive treatment has to be postponed for a bit. And that brings us to the absolute cutting edge of gastrointestinal medicine. We are seeing incredible equivalence in effectiveness and safety between traditional surgical myotomy and the endoscopic POEM procedure. So I want to leave you with this final thought. As POEM allows us to tunnel straight through the submucosa, matching the success rates of classic surgery without a single external cut, could traditional surgical incisions for Achala soon become a thing of the past? It's a thrilling time in medical innovation for sure. Thank you so much for joining me for this complete deep dive on Edumaniac. Keep learning, and I'll see you in the next explainer.